Hello everyone, I'm Waksman. We are at the CRT2014 in Washington, and we are at CardioTube, and with me, Dr. Dominick Angiolillo from Florida. Welcome.
Thanks, Ron.
Dominick, you have done a lot of studies on switching, so I thought that we should talk about switching antiplatelet therapy. So maybe we'll start first with the upstream switching. The patient comes loaded on clopidogrel, now he comes to the lab where we want to give maybe more potent drug. How do we switch? Is it safe to switch? And what should we switch to?
Okay, very good question. So we have learned from clinical trials, especially the Plato trial, that this is actually something we can do and it's safe. And this is with ticagrelor, because part of the trial design, patients who were pretreated with clopidogrel could be then randomized to treatment with ticagrelor. And overall, the data are very consistent, both in terms of safety and efficacy. So that answers that question. With regards to patients who may want to switch to prasugrel, as you know, the CRT2014 did not address that question, but we do have some answers from the Trilogy trial. But unfortunately, this was a neutral trial, but overall there weren't any major safety concerns. But from a practical perspective, when I have a patient who has been already pretreated with clopidogrel and comes to the cath lab, and I believe that patient is suitable for one of the newer agents, I just switch always with a loading dose.
So let's talk about switching backwards. So the patient post-discharge, patient has been discharged with ticagrelor or prasugrel, and then he's run out of funding or bleeding or whatever, and now the question comes with a primary care physician: should I switch him back to clopidogrel?
Very good. So this is where there's a complete gray zone, because we definitely don't have clinical data, and we just rely on some pharmacodynamic data, and there's really not too much out there. The switch that most commonly occurs is, as you mentioned, switching from one of the newer agents to clopidogrel, and most of the time this is either cost or concern of bleeding or whatnot. We do have a pharmacodynamic study coming from Jill Montelasco's group showing that when you switch back to clopidogrel, you have an increase in platelet activity, but you also have a higher rate of patients who may be considered as non-responders. And we do know the prognostic implications of non-responders. Do we have a clinical trial to assess this? The answer is no. We will have a trial coming up soon, which is the Horizon AMI-2, which, as part of the trial design, everybody's getting ticagrelor from the get-go, and then at 30 days, there's a randomization to continue with ticagrelor or switch to clopidogrel. So short of that, it's really difficult. We also have other types of switching strategies, even between the novel agents. One may start with ticagrelor because you're allowed to use it upstream, but may want to switch to prasugrel, for example, because of the dyspnea or because it's once daily and it's more convenient. And we just conducted a SWAP-2 study, and it was very interesting because we actually saw a drug-drug interaction when switching from ticagrelor to prasugrel. And so the general recommendation is, if you're going to switch to prasugrel, always switch with a loading dose, so you could somewhat mitigate this drug interaction.
So that was the other question that I wanted to ask you. Every time that you switch, do you need to give the loading dose, or this is only between specific drugs? Let's start practically. Coming on clopidogrel to the cath lab, should we loading dose with prasugrel?
The answer is yes.
What about ticagrelor loading dose?
Same thing.
Same thing. Okay, so that's an easy one, right?
Yeah.
So the only thing that you suggest so in what case you want going to do the loading dose? Because it looks like in every situation you would.
So for me, I do it in every single case.
There is no basic downside to that.
I personally don't see any downside, and it also keeps things simple for your staff, for your fellows, and say just give them a loading dose, have the drug kick in, because that's the effect that you want to have from that specific drug. Or in other words, go big or go home.
Okay, talking about switching, maybe kind of a little spin of that bridge. You also were the PI of the bridge trial, which was with cangrelor. But in general, the bridging is an issue when you need to send someone on prasugrel or ticagrelor or on clopidogrel to surgery, and you need to stop it ahead of time. So what is right now the best data that you have to tell us how should we do it?
Yeah, unfortunately, I don't have what you may consider the best data because aside from the bridge trial using cangrelor, there aren't any randomized studies, and cangrelor is not an approved drug. So in the absence of an intravenous agent, I would consider a small molecule 2B3 inhibitor, therefore either eptifibatide or tirofiban. I typically stop the oral agent 5 to 7 days before surgery, and after 3 days of washout, start the infusion of a 2B3 inhibitor, and then stop the infusion around 4 to 6 hours before. I do not bridge with a heparin because heparins can actually increase platelet reactivity. And there is some data coming from our Asian colleagues that use salacizole as a bridge because it's a reversible oral agent. And so there are a lot of strategies out there. I do believe that cangrelor will be the most natural bridge, but we need the drug to be approved first.
Absolutely. So the last, again, topic is about those patients who are discharged. And this is going to be a very provocative question, but one thought is that you actually can switch to any drug because maybe you don't need such a long duration of antiplatelet therapy. So in other words, yes, I'm not talking about the STEMI patients, but within the ACS, we can do risk stratification. And some may argue that maybe 3 months is enough, and maybe even 2 months is enough, and you don't need to break your head too much or commit the patient for 12 months. What are your thoughts about that?
Yeah. So very good point, and I strongly believe that risk stratification is key when defining duration of treatment and duration of treatment with a specific drug. We have more and more trial data coming up. Again, I think the trials will provide a definitive answer. But what I can say is that with the data we currently have, it's not a major issue, for example, after 3 to 6 months with second-generation drug-eluting stents, for example. If you want to stop early, in the past, absolutely not, 1 year. So I think we're finding more of a comfort zone. But obviously, we want to see more of the clinical data. And there's some data also looking at how we can integrate platelet function in making clinical decisions to this extent. So again, I look forward to a lot of the trial data coming up.
And you would guide a therapy based on antiplatelet therapy, or you would say solely clinical?
I just go solely clinical. Although you have me invited here to speak in favor, I'm more of a evidence-based person.
Yeah, that's part of the debate, of course. But thank you very much.
Thank you so much. Thank you.